I decided on pharmacy in high school. It was just kind of sort of random. I did a project in high school that was basically shadowing somebody in any career field, and I shadowed a pharmacist, and I just kind of thought from that, well, hey, I like science, and this is kind of cool. I can see myself doing it. So I just kind of took that idea and ran with it, and I did undergrad at University of Florida, and I just did 2 years of pre-pharmacy and then went into pharmacy school there too. So all at UF, go Gators. And then from there, I really didn't decide on a path until rotations during 3rd year going into 4th year. And during that, I had an AmCare rotation. That was my very first rotation, and I just remember thinking, wow, if all my rotations are like this, I don't know what I'm going to choose, because I absolutely loved it. And just from there, I went with the AmCare, ran with that, and did a residency devoted to AmCare for PGY1. And then during my residency, I did a teaching certificate program, and I liked teaching too. And so based on all of that, that's kind of where I ended up here at USF.
I did 2 years at the University of Florida as an undergrad and got an AA, and then I went straight into the PharmD program at the University of Florida at the St. Pete satellite campus.
What has been the path of your career to date?
After school, I started residency at St. Joseph's Hospital in Tampa. There's a general internal medicine residency for a year. And after the residency was completed, this July I started on as a staff pharmacist, and there was a position open in the oncology department, and I had done my research project in the oncology department, so I applied for that job and they accepted my application, and now I'm here. I do half of my work in the oncology center, and then half of my work throughout the rest of the hospital. So the ICU, the main pharmacy, internal med. That's about it.
I chose to become a pharmacist because I was actually more interested in the business side of things. I thought earning a PharmD would help to propel me, so to say, or help to climb the ladder a little bit quicker to more of like a corporate position. And that was kind of like, you know, what I was looking to do when I first came out of school after completing pharmacy school. And that was actually where I first experienced, like, I moved up into a manager position not soon after college. Then I was promoted into a district supervisor position that I did for some time. But I think after a while I realized that I actually enjoy more of that patient interaction, more of that one-on-one. So when my time as an intern pharmacy supervisor had ended, I found myself liking like the actual retail store setting the most.
Can you tell us what education degrees you have earned and from where?
So I graduated from Philadelphia College of Pharmacy in 2010, and I earned a PharmD there.
May you please tell us the path of your career to date?
So the path of my career, again, I graduated in 2010. I became a pharmacy manager within about 7 months of graduating, and then I became a pharmacy manager at another setting. So kind of like they move you into a higher volume store. You kind of climb that way, you know, to see if you can manage like more of a larger team. And then eventually I wound up in a supervisor position where I managed 17 stores. And then again, I'm back into the store that I was at prior to that promotion, here where we do about 3,000 scripts a week.
So pharmacy school was challenging. I think it was a big transition going from undergrad, where the courses are tough, but they're not nearly as tough as pharmacy school. So it definitely took a lot of adjusting, especially during my first year, getting used to the strenuous coursework. But I also had a lot of fun in pharmacy school too, and I think it helps when you really enjoy pharmacy and what you're doing, because then when you're learning things, you're just thinking, I'm actually going to use this, so this is good. So I enjoyed it, and I tried to get as involved as I could. I did Kappa Epsilon, which is kind of a big thing for me, and I met a lot of friends that way. So it was tough on the coursework side, but I had fun with it too.
It was tough. I'm sure everybody says that. I liked the way my curriculum was set up, we did a lot of interacting and role playing and a lot of skits to kind of help you get better at thinking on your feet, defending your answers to a physician, you know, being able to pull evidence-based medicine from your memory, and then it also helped you to become confident when you didn't know the answer, because they taught you to be honest, you know, I don't know the answer, I'll get back to you. And then it also gave you this responsibility because you had to get back to them, so you had to email the professor and tell them, you know, your follow-up answer. So that's the part I liked about it. The tough part was trying to juggle all the classes and all the tests at once, and then trying to find time to watch our lectures. Since it was a satellite campus, we had the luxury of being able to skip a few lectures if we wanted to, so sometimes you would end up with 10 lectures in one day, or some students even ended up with 20. So it was just a big opportunity to develop your discipline and responsibility.
Very intense, so very stressful because it's all about the balance. So when I was in school, I was a part of the sports team, cross country, and that was difficult, kind of like managing my schedule around when am I going to train, what are my races, you know, our competitions. Also working at CVS every week, that was kind of a mandatory thing for me when I was in school. Work about an 8-hour shift every week, and then again studying, and of course everyone knows you're still trying to maintain a social life. So those are like my 4 biggest priorities, and I think it's all about just trying to balance all that out. It can be stressful at times.
I think one of the main things with pharmacy right now is just getting provider status, and I think that's really going to help us make the impact that we want to make, because we go through all this schooling and we really are experts. We've had 4 years of drug information thrown at us, and I think a lot of pharmacy rules right now aren't using that to their full advantage. So I think in the future it's going to be something we're going to continue to try to push, really tell people what we know.
My career's been short thus far, but when I was a student, we went to Tallahassee, to the Capitol, and protested for pharmacists to have the right to immunize. When I was there, it was just for the flu shot, and then after me, they moved on to things like the pneumonia vaccine. And then the current issue that's going on right now is trying to get provider status for pharmacists here in Florida.
I mean, I think one of the hardest things is definitely just managing the business side of things, managing your team. You know, you want to provide and have that time to counsel patients and interact with your patients, but there's a lot of behind the scenes work that you're doing, you know, whether that's making a schedule, maybe counseling, coaching your team one-on-one, trying to develop them to get better. You know, once you can finally improve the structure and the workflow of your store, it opens up that time that you can actually spend with your patients.
Mine's kind of unique because I am in academia, so it's kind of split up amongst a few areas. Clinically, I'm ambulatory care, so I work over at the Morsani Center across the street. And with that, it's a lot of chronic disease management, so I manage patients who are on warfarin. We have a lot of those patients. Diabetic patients I see a lot of. We're getting referrals for nutrition counseling, so I'm having to learn how to treat obesity basically, and doing some of that as well. Hypertension, hyperlipidemia, basically all the chronic disease states I'm managing in the clinic over at Morsani. And in addition to that, I also have the academia portion, so teaching is a big part of what I do, giving lectures here and there throughout the pharmacotherapeutic series, drug information in the first year of pharmacy school, and also serving on different committees throughout the university. So and doing research too, so it's kind of a collaboration of everything.
For the oncology department, we are responsible for double checking the chemotherapy orders. So we have a folder for each patient. We go through their diagnosis to make sure that we have a proper regimen for that diagnosis. And once we get the drugs correct, we have to make sure we have the correct pre-meds and the correct hydration fluids if needed. So we are always double checking the nausea meds, or if they need something like a steroid or an antihistamine before they get their chemo. So that's part of the pharmacist's duties. And then we also are double checking labs. So we'll get a CBC and a CMP for most of the patients, and just make sure that they meet criteria as far as their counts are concerned with the CBC, and then if we need to make any dose adjustments based on things like renal function or hepatic function. If everything looks good to us and we've made all of our interventions, we go ahead and print the labels to be mixed, and then the pharmacist who is mixing that day also goes through that whole regimen again as a double check, because we want to have extra safety for our chemo patients and our chemotherapy drugs. So part of our job in the oncology satellite is mixing also, so your more traditional pharmacist roles. And then on the internal med floors and the ICU floors for our adult inpatients, we do pharmacokinetic monitoring, so dosing vancomycin. We have a protocol for renal adjustments from most of the renally adjusted meds. We can just go ahead and do it on our own. We do have an IV to PO conversion protocol. We do rounds, stand-up multidisciplinary rounds bedside in the ICUs. And then on our general medicine floors, not all of them, but most of them have a physician-led or nurse manager-led multidisciplinary rounds where you kind of all sit in a conference room and go over each patient, so it's not bedside, but you're still rounding. We have residents here, and students, so we do a lot of topic discussions, a lot of journal clubs, a lot of MUEs. And we do have a pharmacist in the ER, so when you staff in the ER, we have the med histories. So the pharmacy department is responsible for collecting med histories for all patients who are admitted through the ER to our inpatient units. And that's a new practice at this hospital, and it's been really successful so far. We've seen huge benefits from it. Our physicians are now getting more accurate histories so they can order the right drug for the patient while they're here. And we do have a pilot program going on right now for discharge med recs, pharmacist-led discharge med histories, to kind of gather all the patients' meds together. So any changes that happened while they were here, the pharmacist looks over it to see if they should continue that at home or if they need to be switched back to something just because we changed it due to formulary. We used to have a program for pharmacists to counsel all the patients before they were discharged, but that became too labor intensive for us, so we kind of replaced it with the med history because we were thinking that we would get more benefit out of that. But we still do it for our high-risk readmission patients, so patients with pneumonia or heart failure. We go talk to them about their medications, why it's important to take them, what they're taking them for, how to prevent them from coming back into the hospital and costing not only themselves more money, but the hospital itself too. We do have a heart failure clinic that the pharmacist goes to once or twice a month, and we counsel those heart failure patients again on their medications. It's more of an outpatient thing instead of an inpatient thing.
So I think there's a lot of opportunity for that. One of the experiences that I had that was awesome was during my residency. So I did it at a family health care center that actually hosted the USF medical residency program. And so it was the first year that they had a pharmacy resident there. And I was working with these medical residents a lot on a daily basis. And they kind of realized how important pharmacy is, just having a pharmacist there, and we collaborated a lot. And I hope to see that moving forward in practice too. And I know over at Morsani right now, the doctors will come to me with questions all the time, and the medical residents there will come with questions. And so we're all kind of working together, and same with the nurses at all these sites. They're all kind of working together. So I think, at least from my experience, there's been a lot of interdisciplinary activity going on, so it's good.
So the biggest area for interaction would be rounds. On the multidisciplinary rounds, you have your physician, the dietitian is there, the nurse is there, social work is there, pharmacy is there. So it's a really productive time, especially in the ICU. In the oncology department, we get a lot of interaction with our nurses. because they're the ones that are, for the outpatient clinic, they're the ones coordinating, getting the orders, and talking to the physicians. So we work really closely with the nurses in the oncology satellite. And then we are decentralized, so that means that our pharmacists sit on the floors for the most part in the nursing stations. And we get to know the nurses really well, especially if you're on that floor for the whole week. So we work with the nurses there, and then it's easier to catch the physicians because they'll be putting in the orders while they're on the floor, or they'll walk by your desk, and you'll be able to catch them quicker if you have a question or a recommendation. And then we also call and text our physicians as the last resort, but even through calling and texting them, they get to kind of know who you are, especially if you're working in the same area.
I think what's kind of challenging at times, so if a doctor's office needs to talk to us, we have our own personal doctor line, and they can call in and speak to us right away. I think what's hard is when we need to follow up with a doctor, it's not always the case. You're always going through a medical assistant or a nurse. You don't really have that direct access to talking with a physician. You're relying on a call back most of the time, so that can be difficult. It's probably the biggest challenge when we're trying to actually communicate with a physician.
So I think that kind of goes back to the provider status and everything there. I think the challenge is just kind of showing people what we can do, because there's a lot that we can do, but people don't know about it yet. And I know sometimes whenever I see a patient, they'll say, well, why am I not seeing my doctor? Why am I seeing a pharmacist instead? So I think people don't really know about all our knowledge, and I think they don't know what we're capable of. So that's going to be a challenge, just kind of convincing people that, hey, we have a lot of knowledge, let us use it. So.
Well, I mean, one of the things we have here is when we are attempting to counsel our patients, a lot of times they come in and they've already self-diagnosed themselves, so there's a lot of information on the internet. You know, not always trusted sources out there, so they have in their mind what they think they might have, usually to the extreme, and you're trying to settle them down and, like, you know, provide them the best care that you can in the direction that they should be going and thinking about, versus necessarily what they're reading and what's out there on the internet.